are not small. Now I invite Professor Salamm Ayaz for an exciting presentation on ECMO Emplacement.
Bismillahirrahmanirrahim. Thank you very much to the organizers for this novel topic, going to introduce as a pioneer, alhamdulillah. Because of the time limitations, I have to try to make it precise and concise. So after the lecture, I shall be available for any discussions. So extracorporeal membrane oxygenation is a form of extracorporeal life support which uses bypass technique to support patients with potentially reversible cardiac and or respiratory failure unresponsive to the maximum conventional therapy. It allows these organs, it is not a cure, but just allows these organs to rest and recover. Principle is simple. Desaturated blood drained via venous or excess cannula, pumped through an oxygenator where CO2 is removed, O2 is added, and after thermoregulation, the blood is then returned to the systemic circulation via either another vein, when it is known as VV ECMO, or artery, when it is known as VA ECMO, to provide adequate oxygen saturation and or delivery respectively. Saturation is more relevant with VV ECMO and oxygen delivery is more relevant with VV ECMO. Little bit about the history. Dr. and Mrs. Gibbon late in 1930s invented the first bypass machine, then in 50s oxygenator, first membrane oxygenator, in 71 first adult cardiac case, 72 first pediatric cardiac case, 75 first neonatal case successfully dealt. Then in the next 15 years, ARDS with VV ECMO, only 10% survival. Then until 2009, when Caesar trial led to a significant growth in the use of ECMO for ARDS, and till 2012, when ECMO became the established entity in the emergencies for the cardiac failures, only in the few centers in the world. She is Esperanza, the first neonatal survivor at the age of one day, then 21, and she is now working as cardiothoracic surgeon in US. The first this oxygenator with cardiopulmonary bypass machine in 71, and over 50 years, these are the latest machines, Rotaflow, CardioHelp, Xenos, and in this CardioHelp, which I have been working on, is the most considered as one of the most smart machines. Just as a bridging therapy, ECMO is used, either bridge to recovery, bridge to decision, especially during the CPRs, when you take up the patient on ECMO and then you have time to decide how to proceed. And then most important is bridge to transplant to provide, and during this period, ECMO provides support to the patient while on the waiting list. And this is significant for the lung transplants as well. About the equipment, this is the console. Over here, this is the main console or CPU. This is the centrifugal pump, oxygenators. This is the gas blender. And this is the flow meter, heat exchanger, cannula, and tubes. Basically, this machine works as a 4 parts. Heart, it can replace heart, lung, thermoregulation, and kidney. So basic components, inflow or drainage cannula, then is the pump, oxygenator, heat exchanger, return cannula, and these are the pressure measurements. This is the pre-pump pressure, this is the pre-oxygenator pressure, post-oxygenator, and delta pressure. It has very significant role to assess for any troubleshooting during the ECMO flow. This is the actual machine, ECMO, which I was showing to you. This is the oxygenator, pump, these are the tubings, this is the flow meter and gas blender where air and oxygen mixes. So centrifugal pump, in the cardiopulmonary bypass machine, the pump is of roller type. But over here in ECMO, we use the centrifugal pump. The beauty of this pump, it works on the constrained vortex where an object spins in the fluid to create an area of low central flow and higher outer flow. So with the help of this technology, we can run this ECMO machine over months. And this is the major difference between the cardiopulmonary bypass machine which we use during the CABG. Over there, we use the roller pump, which can only support for hours. And it can give you, up to 8 liters of flow. This is the oxygenator. Basically, in the oxygenator, there are 3 types of flow. One flow is of the blood, the other flow is of the sweep gas, and the third flow is of the water, which thermoregulates and control the heat of the. Initially in 1950s, which I was showing, it was the silicone membranes, now replaced by polymethylpentene membranes. These are the modern ones, and which are more efficient, prevent leakage and stasis of blood. Basically, this is the interface. Inside this membrane, there is gas, and outside this, there is blood flow. So because over here, most of the pulmonologists, mashallah, eminent pulmonologists are there. So if you are providing the VV ECMO support to the patient, how to increase the oxygen on the VV ECMO? It depends on the membrane material. It depends on the FiO2, which you control from this oxygen blender. And it also depends on the hemoglobin concentration. And how you control the carbon dioxide removal on the VV ECMO flow? Sweep gas. From here, you can control the flow of the sweep gas. The more is the flow, the more CO2 will be removed. The other one is the ECMO flow. The more blood flow through the machine, the more CO2 will be removed. And the other one is the presence of water vapor in the membrane. In the modern membranes, which I showed, these are more compatible and less water vapor accumulation on the membranes. Then the tubings, very important. The large volume circuit should be avoided at its exposure to inflammation, thrombosis, and heat loss. Because extra corporeal circuit hota hai, to usme all these complications can be there. So we try to minimize the volume of these tubings. And then is the heat exchanger. What is the purpose? You can thermoregulate the patient to decrease the oxygen consumption for the neuroprotection and for fever control. And this is especially important when you are using this V-ECMO mode during the CPR. You can easily induce thermoregulation to protect the brain. Then cannulas, two types of cannulas. This is the aortic cannula or return cannula. It is basically single outlet hole, and the other one is the venous or excess cannula. We take the blood from the body through this venous or excess cannula. It has multiple inlet holes, larger in size. And this is the return cannula or arterial cannula. It has only single outlet lobe. Over X-ray, you can have a view of these cannulas. This is the return cannula, this is the excess cannula, and the distance between these two cannulas is important because if it is less than 10 centimeter, recirculation can occur and your oxygen saturation may compromise. So we have to keep this distance between these cannula. You can see the upper end of this cannula over here and the lower end over here. So what is the basic difference between V and VV? V-ECMO facilitates gas exchange as well as near complete cardiac support. But in V-ECMO, only gas exchange, no cardiac support. So it provides the oxygen delivery, it ensures the oxygen saturation. And in this configuration, we can have venous and arterial access, but in venous side, we can only go for the venous cannulation only. It can be peripheral or central, but this is only peripheral. So in VV-ECMO, venous blood is accessed from the large central veins, pumped through the oxygenator and returned to the venous system near right atrium. It has four types of configuration. More common and important is femoral. From one femoral vein, you get the blood out for the machine, and after oxygenation, it goes in through the other vein. So this is veno-venous. Another configuration is you take the blood out from the femoral and you take it in from the subclavian vein. And this is the double lumen AVL cannula over here. This is a single stage cannula. You can put it in the SVC. It has both the option. In the same cannula, you have the access as well as the return. You take the blood from IVC and SVC and you return it towards the right ventricle. And in the modern setups, this cannula is being used because this is more convenient, easy to access, and easy to monitor. Then V-ECMO, again having the same configurations, FEM, femoral carotid auxiliary, or it has a peripheral cannulation from the femoral vein. You take the blood out and you put it in the femoral artery on the other side. This is peripheral V-ECMO. But in the central access, you have to make the chest open. This is being used during the bypass surgeries or even for open cardiac massage when you take the blood out from the right atrium and you send it back to the ascending aorta. Indications of VV-ECMO. Reversible respiratory failure. In the very start, I told you that the pathology should be reversible. Unless you are planning to proceed for lung transplant. So in the reversible pathologies, or these entities, ARDS, severe pneumonias, acute asthma, inhalational injury with acute HP, near drowning, post-traumatic contusion, bronchiolitis obliteratis, and this is vasculitis ghost posture. Unless you are doing the lung transplant, when you take the patient on ECMO and you proceed for wait for donor and waiting list. This is a Murray score, very important. For the selection of the patient where you have to initiate the VV ECMO. And take it, this very important message that careful patient selection is extremely important for your outcome on the VV ECMO. Murray score depends on PF ratio, X-ray, PEEP, and compliance. And this total score you have to divide by the total number of parameters, and you will get the score, Murray score. So in the hypoxic respiratory failure, you will start considering the initiation of ECMO after the failure of mechanical ventilation when your PF ratio remains less than 150 and Murray score between 2 and 3. Over here, you have to consider the ECMO, but these are the definite indications when the 80% mortality risk with the PF ratio less than 100 and either Murray score is between 3 and 4. Then in the other indications, CO2 retention on mechanical ventilation despite high plateau pressure greater than 30 centimeters, severe air leak syndromes, or need for intubation on a patient on lung transplant list. Currently, what criteria we are using, and our physicians should know that this is our cutoff to start with the VV ECMO. You have to keep in mind this criteria. PF ratio less than 50 for 3 hours, PF ratio less than 80 for 6 hours, or pH less than 7.25 for greater than 6 hours means type 2 respiratory failure with plateau pressure more than 32 centimeter. And this is exclusion criteria. Mechanical ventilation on high pressure for more than 7 days, age less than 18, pregnant patient, BMI, morbid obese, prior O2 dependence, history of heparin-induced thrombosis, malignancy, neurologic devastation, DNR. But mind it, there is no absolute contraindication for the ECMOs. These all are the relative indications. And this depends on, the setup and their expertise. These are the VE ECMO indications: unable to wean from cardiopulmonary bypass machine, bridge to cardiac transplant. This is very important in the setups which I've been working. They are doing, large volume of transplants over there. Then the refractory cardiac shock, acute myocarditis, pericardium, cardiomyopathy, bridge to LVADs, intractable arrhythmias, pulmonary hypertension, when you are especially planning these patients to proceed for heart-lung transplant, so you can initially support these patients with VECMO, and post-cardiac arrest, ECPR. As I mentioned, no absolute contraindication, but in severe chromosomal or unrecoverable comorbidity, terminal malignancy, CNS damage, all these are depending, because there is high running cost of the ECMO, so you have to weight between risk versus benefits, and these are the relative contraindications already I have discussed. In the mechanism, whenever you plan to initiate the ECMO, the patient is initially, you have to anticoagulate the patient with IV heparin, and cannula are inserted according to the ECMO configuration. Then when you start the ECMO, you have to initially set the flow, and this is how you set the flow: 20 ml per kg per minute for the initial hours, and then you keep on increasing by 10 ml per kg per minute till you reach the desired flow. Desired flow actually we calculate with the body surface area and cardiac index. This is, I will conduct a workshop on it, and further we can discuss it over there. Initially, the blood flow and gas flow ratio should be 1:1. If your blood flow is like 4 liter per minute, gas flow rate should also be 4 liter per minute. This is the main initial setup. And FiO2, as you do it in the mechanical ventilation, you have to start with the 100%. And once desired flow achieved, ventilator settings are brought down to initiate ultra protective ventilation. You mind it? Just 2 minutes. Just mind it. This is just, ECMO will buy you time for the lungs to recover. This is not something which are going to, catch all the disease out of it. And inotropic sport, you may also wean off. In the VECMO, adequate tissue perfusion is determined by MAP greater than 60, and this SCVO2 oxygen venous saturation of 70 to 80%, and then the blood lactate levels. Heparin protocol: in the initial hours for the VECMO, you have to give 80 units per kg IV bolus, and for VVECMO, 60 units per kg initial bolus, and then you have to maintain the SLIX. In VECMO, 18 units per kg per hour, and in VVECMO, 15 units per kg per hour, to ensure that your hemoglobin should be more than 80, platelets more than 50,000, fibrinogen more than 1, INR less than 2, and 83 level. For the heparin to work, you need to maintain a certain level of antithrombin 3, and the level should be between 80% to 120%. What is your ultra protective mechanical ventilation when you are using VVECMO? You use PCV mode, pressure control of 10 to 15, rate between 10 to 15, PEEP between 7 to 10. So for the ultra protective ventilation, you just try one number which is 10, 10, 10. Your pressure control should be 10, rate should be 10, PEEP should be 10. And this will constitute the ultra protective ventilation for the lungs due to VV ECMO run. FiO2 between 30 to 40%. And then you continue, all the patients on ECMO require analgesic sedation. Usually we use morphine and midazolam, but propofol can also be used. And we have to all the time keep the hemoglobin around 10. Neuromuscular blockade can be used as per patient profile. Then in the machine, we can also remove the fluid, and we can also give the patient to renal support if we can add this membrane to the ECMO circuit. It also works as a ultrafiltration. In the nutrition, we usually prefer the enteral nutrition, but as per the patient requirement, we can go for the, just madam, 2 minutes. We can also start with that parenteral. GA prophylaxis can be given. Prevention of infection, because we are controlling the thermoregulation, the fever may not be evident on the patients on ECMO, but all the time you have to go for the inflammatory markers, for the septic markers, and you have to follow the VAP, CLEPSI, and COTI bundles. On the ECMO now, with the advancement of the techniques, this patient was a candidate for the lung transplant, and you can see that on VV ECMO he is doing the exercise during the ECMO run. And now even patients can be mobile with ECMO. In the weaning trial, for the VV ECMO, we have to ensure that when the improvement in radiographic appearance, pulmonary compliance, PF ratio, and pH. So we have to start thinking of the weaning of VV ECMO. And on these ventilatory settings, between tidal volume 6 to 8, PEEP between 6 to 8, and FiO2 less than 50%, if the patient is maintaining his gases and clinical profile, we can plan to wean this patient. For the cardiac failure on 3 days, and for the lung failure, 2 weeks are enough to assess if the patient is weanable or not. Among the complications, bleeding, thrombosis, HIT, thromboembolism, air embolism, and certain specific, this oxygenator thrombus is very common complication on VV ECMO. How you will assess that the patient, that the machine oxygenator is not working? You will get hypoxia and hypercapnia on the VV ECMO run. You can have increase in the pre-oxygenator pressure. Clots can be visualized. If large clots, you can visualize grossly, but with a torch, you can easily assess the oxygenator that whether clots are there or not. And if this oxygenator fails, it has very high cost to replace it. So all the time, we have to keep the run of heparin to ensure that there should be no clot in the circuit. Then again, as I mentioned earlier, if you, in the VV ECMO run, if your cannulas are too near, there should be distance of more than 10 to 15 centimeter. If less distance, the oxygenated blood will recirculate through the machine and the patient will becoming hypoxic. So all the time you have to maintain the at least around 15 centimeter distance between the two cannulas. VA ECMO, we shall discuss later at time. Just a brief, registry record of ECLS registry. Till January 2016, 58% survival was documented, and these patients were either discharged or transferred to the step down. So this was the registry record yet. In the CPR, if patient is on VV ECMO, you have to, and patient becomes cardiac arrest, you have to exercise the ACLS protocol. But on the VV ECMO run, if your pump is working and producing more than 4 liters per minute, you don't need CPR. And in the CHEER trial, they have shown that cardiac arrest out of hospital or in hospital, more than 50% survival was there on the extracorporeal VA ECMO run after the CPR. And this was a very high number, and now these numbers are even more increased. This is a Caesar trial, 2009. Survival rate on ECMO was 63% versus 47% on the mechanical ventilation, and mortality was 37% versus 53%. Over here, we have to answer this, that ECMO is a safe, efficacious, and cost-effective treatment, and it clearly showed that Caesar study supports ECMO as a valid treatment option for the management of patients with respiratory failure. However, 24% of the patients in the ECMO group not actually receiving ECMO, so there was insufficient evidence. Still, this Caesar trial and later this ECMO trial, this is jet the most largest trial of VV ECMO in the adult patients yet available, and it showed there was some caveats. They have to curtail this trial earlier, but still, even it clearly showed that ELIA provides, though inconclusive, but it suggested that a possible clinical benefit from ECMO over standard care, provided you initiate this ECMO early on, well in time, and the physician who are trying to incorporate the patient or referring the patient for VA ECMO must be knowing that time is important, when to refer for ECMO, because the sooner is better, always better on the ECMO, and if you initiate it late, then you won't be able to get the results. And these are the results ECMO used in COVID-19. They showed that later in pandemic, patients more often had non-invasive ventilation before ECMO and were given steroids and other specific COVID-19 therapies. That's why in the later part of the ECMO, especially after May 22, there were more mortality as compared to the trials of ECMO before May 29, but still they were of the conclusion that clinicians should be trained enough to decide when to initiate the ECMO, and whenever you are in time, ECMO is still in the best, and it is now a part and parcel of all the algorithms of ARDS whenever mechanical ventilation fails. Thank you very much for the time limitations. You are welcome enough to contact me anytime, and I shall